I'm quite happy because it links very well with what Heather was talking about earlier. We didn't talk, but it does. So, are drug-drug interactions still a concern when we prescribe booster-free antiretroviral therapy? This is a little bit of the context of the case, and the reason is not only because Heather gave you a fantastic introduction, but it's because this is a question that I am asked very, very much in clinic. Of course, without the booster, it's easier, but they're not all gone. Okay, so this is a 39-year-old man who's been positive since 2004, baseline resistant test, undetectable viral load, CD4 310. He's on TAF, FTC, raltegravir 400 milligram twice a day, and that is when at 5 o'clock you think, I'm going home early today. Nope. So, that's the list of comorbidities and co-medications. He's obese, he's got insulin-resistant asthma, COPD, depression, neuropathic pain, heartburn, hypertension, osteopenia. So he's on a waiting list for bariatric surgery, he's on a diet, he's got fluticasone inhaler, mirtazapine for mental health, gabapentin, omeprazole, ramipril. And that's when you say, I'm not going home early. Again. So in terms of antiretroviral history, we're quite lucky because he actually never failed, but he had a long history of toxicity to different antiretrovirals. So you're not only thinking from a drug-drug interactions point of view, he's on polypharmacy, I need to be careful here. You're also thinking he didn't tolerate efavirenz, he's on omeprazole, so atazanavir is out of the question, he had a very bad rash with the cellulitis to darunavir. He wanted to simplify his raltegravir BD to once a day. He had dolutegravir, didn't tolerate it, had insomnia, anxiety, had a fall, he broke his wrist, so doesn't want to take it again. And then when he simplified raltegravir to once a day, he had very important headaches, so he went back to BD. So that is why he's on TAF, emtricitabine, and raltegravir BD. So, obesity and bariatric surgery. There are some very useful guidelines that I work with, I reviewed with the pharmacist. Our pharmacist, this is again to underline the importance of working with the pharmacy, because you think, oh, she knows everything about pharmacology, she can do it, but this really is a headache. You need the pharmacist there, believe me. So the guidelines on postoperative micronutrient replacement for patients undergoing bariatric surgery are very useful, and you can see that supplements with iron, calcium, zinc, copper, and selenium needs to be taken 4 times a day for a few weeks, and then less frequently, but lifelong. Okay, so here we go. We have this guy on raltegravir that needs all of this soon when he needs bariatric surgery, and then just after the bariatric surgery. So that's the drug-drug interactions that is important. Then the asthma, so he's on fluticasone. So as you know, there is a need to avoid boosters because ritonavir cobicistat can boost, by the inhibition of cytochrome P453A4, increase the steroid level, and we see people in clinic with iatrogenic cushingoid because they are on the booster and fluticasone or other steroids. And this is the Liverpool website that shows you that unless you are on dolutegravir or raltegravir and or NRTIs, there is a potential interactions with steroids. In terms of neuropathic pain, he's on gabapentin, but he's not responding to gabapentin, and the neurologist and the pain specialist would like to try carbamazepine. Oh no. So carbamazepine is a strong inducer of several metabolic pathways, cytochrome P453A4, glucuronidation, and so on. Now, if you look at the Liverpool website, drugs like dolutegravir, maravir, and raltegravir are amber. Some are red, so carbamazepine injection is too strong. You need to avoid co-administration. Some are amber. So there is no study looking at carbamazepine and raltegravir, and I am sure we have people on carbamazepine and raltegravir because actually, although there is an induction of glucuronidation and the levels of raltegravir can be lower, sometimes we really don't know what to do, and the raltegravir is twice daily. My only concern is that in this patient, we really need to be careful not to burn the raltegravir. I'm not saying that in someone else you would risk a drug interaction. And yes, you can do TDM of raltegravir, but you know, first of all, it's now TDM is done quite rarely, but second, as you know, the results of the TDM of raltegravir are very difficult to interpret. There's a massive intra and inter-individual variability of the results. Sometimes we look at it and it's like a number. We really don't know what to do. Does it mean we have to remove the carbamazepine and so on? So that's something we're working on, but the interaction may still matter. And so we said, what about valproate? We were all happy. And then we had the bad idea to look at the Liverpool website again, because if we didn't look, we didn't know. Unfortunately, we decided, but valproate is okay, right, with raltegravir integrase inhibitors. And here you go, the dolutegravir and raltegravir are again amber. And this is because there was a study done in few patients on valproate and dolutegravir that showed that there was a decrease in 80–90% in the dolutegravir area under the curve in people on valproate. And they suggested either because the valproate contains magnesium at high doses that might have blocked the absorption, but there are valproate formulations without magnesium, we triple checked, but the other potential interaction is at the level of protein binding. But then I'm questioning the clinical relevance of it, because sometimes the drug interactions at the level of protein binding means that there's more free drug, but it still works. It's just that you can't measure it. Sorry, I'm going a bit complicated, but this is all, you know, we don't know very much. Obviously, you would monitor a viral load very quickly, so but very, very frequently you can do it. But what about raltegravir? Are we still concerned because we saw a decrease in dolutegravir? And again, lack of data, a number of interactions in someone who is quite complex, where again, we can't afford to ban the raltegravir, I think. And then he's got heartburn and he's on omeprazole, but he forgets to take omeprazole, so he takes antacids over the counter. It's much easier. So that's when it's now 6:30, you're still there and you start sweating, and you explain that with raltegravir, there is an interaction at the level of absorption. All of these summary of product characteristics are a little bit different. Raltegravir once a day is a little bit worse because you really should avoid all kinds of antacids. With once a day calcium containing antacids are okay, so you need to tell him what are the antacids that he can actually take, so it's worth spending some time, and here you go again. My experience is that I sometimes just see the patients together with the pharmacist. We do this together, especially because when he comes back, if there is a pharmacist involved in the care, it's all very well documented, very clear. They have very good handovers. So I find this guy is managed by me and a pharmacist together every time. There is too much going on. So, you know, this is for raltegravir. Trough concentrations are remarkably decreased by aluminum magnesium containing antacids. But again, raltegravir BD with carbonate antacids is okay, calcium carbonate antacid is okay, but the OD is not. So that's not only you need to remember every single SPC for every single integrase inhibitor, you also need to remember that raltegravir once a day and twice a day is different. And this is the study showing that the once a day raltegravir with all kinds of antacids is not recommended because there was a remarkable decrease in C-trough even when they were given 12 hours apart. So again, we're not prescribing a booster, so we're not prescribing an integrase inhibitor in antiretrovirals with a high potential for drug interactions. We are definitely in the low potential for drug-drug interactions, but there are still drug interactions that may matter, they complicate care delivery. We're going to learn and place bictegravir very soon. As soon as Professor Beck updates his slides, we can nick them again and we'll know where to put bictegravir, no pressure. So this is the what's happening now. Unfortunately, not very happy ending, but this is ongoing. So he came back to a clinic a month later saying he stopped his antiretroviral for a week. And his viral load was 8,000. And so he saw a doctor that restarted valtegravir 800 milligrams once a day, which is a little bit annoying because you shouldn't do that. We did use valtegravir 800 once a day, but in people that were undetectable. I'm not really sure what the doctor thought. So that was a bit scary. And I'm saying this honestly because I think it's important for us, for a clinical team, to know that mistakes happen all the time. I'm surprised it went through pharmacy, actually. I haven't checked that because our pharmacies are like gatekeepers, very strict. So Nali runs the team, so you can imagine. 3 weeks later, he comes back to the clinic and his valtegravir dose was increased to 1,200 once a day because he didn't want BD, he was taking more supplements, calcium, vitamin D. He was worried about DDIs, he wanted to simplify whatever, and so the viral is still 150. This is literally a couple of weeks ago, and we're going to give one more shot and see if it goes undetectable on 1,200 and then hopefully find a solution. So HIV management goes very much beyond viral loads, and drug-drug interactions are inevitably part of management of people living with HIV, and I think we should manage them all together, doctors, nurses, and pharmacists. Obviously, the Liverpool website is fundamental, and we use it for every single drug just to make sure. It's also, again, the valproate is an example, is just updated very, very quickly, and sometimes rather than go through the whole literature, PubMed or whatever, you just find the answers there. Thank you very much. Questions? Yes.
You know, with the carbamazepine and the levels with the valtegravir, and I understand the individual variability, but could you, if you really needed to use it in those situations, do a valtegravir level pre-changing? So you've got that patient's level. You
can, but then...
I mean, if you're stuck.
Yeah, but again, the problem is the intra-individual variability is very high too. So even without the carbamazepine, if we take valtegravir and we measure it today and in 2 weeks, we might see a massive change and you wouldn't know whether it's a carbamazepine or not. You can try, but it's very hard. You would need a lot. You would need almost a population PK in N=1 to see what's going on, to see if there's a trend. You can double valtegravir dose to 800 BD. I remember doing it in someone in Dean Street who had a viral load of 20 million and was on oxycarbamazepine, lamotrigine, and many others. So I thought, I'm going to leave him on 400 BD when he's undetectable, but I need to think about the pharmacodynamics too. And I remember giving him double dose of RAO, but it was much easier from a co-medications, polypharmacy, polymorbidity point of view. So yeah, you could, but it's not reliable.
Thanks very much, Marta. I mean, I think you've highlighted some really interesting things that we struggle with all the time. And one is where you get a difference between the SPC and the USPI, for example. So people have looked at the same data and come with a difference. And that's actually with bictegravir, for example. There's a difference between the USPI and the SMPC about whether you should separate, how long, take it with food, etc. So that's an issue. The other issue is with calcium in antacids, so that some clinical trials were done with 1,200 calcium, another with 3,000, and then people say, well, what about a glass of milk which has got 300 mg of calcium, or Gaviscon which has got 200 mg of calcium, so you've got this range of calcium. Where's there a threshold? And we actually don't know. What you need to do is a clinical trial with different amounts of calcium, going from 200 up to 1,000, up to 3,000, and actually answer where the threshold for some of these issues, because this is practical day, you know, it's really important, because all these massive range of over-the-counter and calcium supplements and stuff.
We have applied for funding to do it.
Good. When's the answer? when do we get the answer?
I don't know, because they haven't approved it yet.
Marta, your patient, if you're giving him carbamazepine, obviously there's the TAF issue as well. he's someone, so I'm thinking about dual, and the US guidelines, for example, are still quite conservative when it comes to dual and say you should only use dual regimens where you can't use TDF or abacavir or TAF. And there aren't many patients where you can't use one of them.
His problem is not TAF, his problem is the third agent.
But the carbamazepine, you can't give with TAF, can you?
It's decreased, but there's no, it's probably okay.
So you think that would
The intracellular levels of TAF with carbamazepine, I don't think it's going to be lower than with rifampicin. They did a model, this was a 75% decrease, but I don't think it's an issue because with rifampicin we saw a 77% decrease in intracellular levels of FVDP, and it was well above what you achieve with TDF on its own. I would be very surprised that that matters because it doesn't matter with rifampicin.
Okay.
Sorry,
Yeah,
it's very important that I specify that.
Yeah, no, because we've had a couple of cases with sort of complex pain control or epilepsy issues who have been on TAF, and it has been, we've assumed that you can't. So you're saying if it's the clinically best regimen that it's probably...
Yeah, I think the intracellular levels are satisfactory, yeah.
So, Marta, just going back to the supplements, I think the issue really is, it's so hard to know. It's not a large reduction by and large. And we think that in drugs like dolutegravir and probably bictegravir, we're probably giving a lot more than we need. That's why we're not seeing failure. So I have in my clinic, I have a situation where I have patients who have hemophilia. And many of them need to take iron their whole life. So here it becomes a little bit different. So this now becomes forever. And then I start thinking about, shit happens. So this person, for the rest of their life for now, need to make sure to take it either with food or separate. And I start, multiplying it not by, let's say, 2 or 3 months, but by, thousands of days. And then you start worrying about the perfect storm. So, okay, let's say do that, and then they have an interaction that we would consider. Then they miss 2 days, and all these calculations. So I think, we're in HIV we should be cautious. Because you see a study, and looking at that study, I'm saying, well, that probably will be okay. But if I'm told to take a pill with food or to separate them by 12 hours, and I have to do that for a few months, that's one thing. If I have to do that for years and years and years, I'm really cautious about that. I can't tell you guys how goose I am. Actually what I do with many of my patients, since we're a hemophilia center, so we know how to give iron IV a lot. And if I'm not really, I just say, no, why don't you come in, we'll give it to you IV, and I'll sleep better at night. So, some of these, I think, we have to put that touch in and consider, the long-term effects of these are different than when you give something for, for a certain amount of time. So I think, we're still learning. I think this is still a learning process. But again, and the more we do this, you were mentioning, Laura, how we get this information out. So these things, it's amazing. If something can go wrong, it will go wrong. So it just seems that we can't be careful enough with these, with these things and using it. So I guess here again, there's something where, at least in my clinic, drug-drug interactions are on me, not my nurses. We don't really have a pharmacist. We have a pharmacy service, but they're on me. So it's a little bit different. So my nurses will take responsibility in a lot of things, but not drug-drug interactions. That'll be deferred to me, and I'll defer to the, to my app of the Liverpool. But in the end, the buck stops on the doctor. I think here we should also give some, some thinking, because I'm involved in resistance, and we do the Stanford Drug Resistance Database, but I also help out David's gang a little bit with the Liverpool. And it's changed. 20 years ago, we were doing tons of resistance and drug-drug interactions. Those poor clinical pharmacologists, we threw them a bone every now and then. They gave a talk, And look what happens now. The Liverpool app is being downloaded, like crazy every day. And the Stanford database, every now and then, someone, does us a favor and pushes. So something, something to give, give thought about where we're going with that. Anyway.
Oh, there's more questions.
Marta, I just wanted to, you talked previously about novel drug delivery, and we're talking here about drug interactions. And one of the issues that we come across a lot, I'm sure you must do, is when you'd like to know more about the patient's genetics. So, in this patient, is a drug interaction likely to be more likely or less likely? Because, are they a poor metabolizer or an extensive metabolizer?
Yeah,
do they have X, Y, or Z?
that's good. So it's a little bit complex because sometimes the genetics is meaningless in view of a drug-drug interaction, sometimes can help. I can give you 2 examples. So in the context of 2D6 and metabolizing mental health drug and being a fast versus slow metabolizer, a drug-drug interactions wouldn't add anything on top of the activity, to the activity of the 2D6. In the context of 2B6 and efavirenz and rifampicin, genetics was important, and in populations, so not only in single patients, but in populations with a high frequency of slow metabolism or SNPs like the 516TT, rifampicin had a less effect on efavirenz exposure, okay? So it depends what genetics it is, what is the main metabolic system, and what is the genetics behind it. There's no rule for genetics and drug-drug interactions balance. In this context, we are in a UGT 1A1 28 potential polymorphism. Laura Waters is an expert on the field, I've heard. And so what you might want to do is first thing to see the percentage increase if you're a slow metabolizer compared to the effect of the percentage of the drug-drug interactions and see whether they counterbalance. But if the drug interactions is a strong induction of glucuronidation, the likelihood for the SNPs of being a slow metabolizer at the level of UGT to be meaningful is low.
What about if when there's an alternative pathway though? So if you're a poor metabolizer by 2D6, and then which then means that 3A4 becomes the main pathway.
So in the terms of the induction, then so in 2D6 is possible. There's some drugs that are mixed, but in terms of the induction, the drug is, if there's an induction, it would be on 3A4, for example. So if you're a fast metabolizer on 2D6 and you have an inducing agent, you have no drug. But I think that if you're a fast metabolizer on 2D6, that's the most important thing anyway, okay? So it is a bit difficult, but you need to have a look at one by one if you really want to see and what metabolic pathway is affected and what's the genetic behind it. So if the impact on carbamazepine is relevant, I don't think that being a Gilbert carrier matters very much. Okay. Do you agree with me, Professor Beck?
I mean, I think it's really complex, the gene-drug interactions. I think, what we're talking about is with something like venlafaxine, if you've got a gene polymorphism that makes it a poor metabolizer, pushes it down the CYP3A pathway, what actually happens to that pathway if you've got something that's going to interact with that, which you wouldn't normally see. So you maybe uncover a drug interaction. And so there's a lot we don't know about that as well.
Yeah, so it depends a little bit drug by drug, what pathway they use, if it's one single pathway, if it's a multiple pathway, and how much the single pathway is affected. So does it make sense? So it's not an answer yes or no. And in this case, I don't think it would matter very much, but I'm happy to be wrong. We're not going to send the genotype.
No, I wasn't thinking about that, thinking more generally, whether you thought that would be something that might happen in future, or is it going to be too complicated?
I think it's too complicated, yeah.
Just from a patient perspective on interactions with minerals and vitamins, I come across this quite a lot in community forums, peer support, where I find where a pharmacist is involved, then people better understand the interactions there, but where a pharmacist isn't involved, there seems to be more confusion about, what antacids you can take, the minerals that you can take. There was a question today about iron and maltegravir, and I'm not sure about that. I thought it was calcium and zinc, selenium, those kind of things. So it's just, I guess, education in terms of these kind of interactions and treatment literacy, really, amongst patient groups.
Absolutely,
Really
and
important.
also with your help, as we did before, designing the right study. So it's important when we phone you, we're designing a study, can you help us? This is another good example, because it would be good, not only what I want to know, because I think pharmacology is exciting, but what you want to know. So we are at this stage. I might email you very soon again. But yes, absolutely. I think we don't have the right data in this at the moment. Like David said, we need to do the right study. Yeah.
Well, thank you, Marta.
Thank you.